joining us today. But that doesn't mean that we can't talk this out. And absolutely, I think there'll be a lot of opportunities for discussion. The discussion is really what makes this rich. So if you have questions, please join in. And we sort of designed it where the clinical cases are opportunities for discussion. And so I really want to hear from everyone out there, especially the clinicians, when you would treat and when you would not treat in some of these cases. So we're going to get less into the weeds about specific antimicrobial choices and regimens and really talk about whether or not to treat in these cases. I think that's the heart of the discussion here. And then I wanted to thank my colleagues at Divine Savior. We actually demoed this presentation during our med staff meeting. So for those of you who are listening again, and for everyone out there, really, thank you for spending your lunch hour talking about urine. That's a brave choice. I hope it's high yield for you. I have no conflicts of interest, and our aims today here are pretty simple. We're going to give some background on antimicrobial stewardship for those of you who are new to the topic. Again, we have 130 participants. I imagine some of you are just getting into this topic. Some of you are probably clinical experts. We'll really do the deep dive on asymptomatic bacteriuria. You feel free to say ASB. I've said those words about 10,000 times, but it's absolutely a tongue twister. So asymptomatic bacteriuria, or ASB. And we'll get into a definition about that, but I'm going to leave that hanging for just a moment as we look at our first case. And then for each case discussion, if I could ask at least one brave soul, we don't have to all weigh in, but one brave soul to get on the audio and let me know whether you would treat or not and why. And that's going to really spur some discussion here. And a lot of this is fluid, right? There's no right or wrong answer. It's about what your clinical gestalt tells you. But we'll get into best practices, evidence, and gaps between usual clinical practice and best evidence, and hopefully bust some myths and give some guidance on those topics. So we're going to dive right in. This is our first case. It's a 43-year-old female. She has a spinal cord injury at baseline, and she's coming into clinic today. So she actually has an indwelling catheter. Some spinal cord patients are doing intermittent self-cast, but she has an indwelling catheter. And she has been vomiting for a few days. Non-bloody, non-bilious emesis. Her vital signs are good. She's not septic, but her UA is strongly positive. That means it's a clean sample. It's got bacteria, leukoesterase, WBCs, and nitrites. And the question is, does she get an antibiotic or not? So I'm looking for my first brave soul to weigh in. Would you treat or not, and why?
Hi, this is Dr. Gerber. I say no.
Dr. Gerber, thanks for stepping up. What's your thought process on that?
Well, in a patient like this with an indwelling catheter, the urine is going to be colonized. I guess unless she was showing signs of sepsis with high fever, shaking chills, other symptoms that might affect my judgment on antibiotics, but that's not what I'm hearing here.
Yeah. So I totally agree with you, and more importantly, the evidence totally agrees. So this is, the point of this case is a high-risk population, which you correctly identified. So this patient has a catheter in, which is a source where outside bacteria can enter the bladder on a routine basis, and they're highly likely to be colonized. So they are at high risk of having asymptomatic bacteriuria. So in the patient with a spinal cord injury or a long-term indwelling catheter, we're really only treating for UTI if we have clinical signs of deterioration like sepsis, fever, or flank pain. And so this is a case where this patient likely always has bacteria in their urine, and you would not treat. Let's dive right into a definition then, just to kind of set the stage here. So ASB is an asymptomatic urinary tract infection. Another way to say it is an isolation of bacteria in an appropriately collected sample in an individual with no signs or symptoms referable to a UTI. And a pretty glaring number here is 80%. So 80% of the time when clinicians treat an asymptomatic urinary tract infection, that is not based on guidelines from the Infectious Disease Society of America. And that number will come up again and again. I want it to stick into your head. So this is one of these opportunities for quality improvement where we're really seeing a massive gap between usual clinical practice and best available evidence. The epidemiology here is interesting. So ASB is out there in a lot of different populations, some more than others. In healthy women, it's around 2 to 5%. In the pregnant population, it's 2 to 11%, presumably because of some mild degree of functional limitation, and then the actual uterus pushing on the bladder. Diabetic women sometimes have actual glucose in their urine, which is a food for bacteria. The presence there is 7 to 9%. In our nursing home population, we see a really wide variance. So the studies show that it's somewhere from 5%, which is essentially the normal population, up to 50%. And a lot of that has to do with functional limitation. So when patients, for example, are not voiding frequently because of mobility issues, or if patients are not able to clean as well because of mobility issues, those put you at increased risk of ASB. In our intermittent cathing spinal cord injury population, ASB is now 50%. And so I think at that point, your urinalysis is becoming not very useful anymore. And in our long-term catheter population, there's not a lot of 100% in medicine, but we are nearing 100% colonization in our long-term catheter patients. So those are really populations where your urinalysis becomes a less useful tool. And again, 80% discordance between recommended practices and actual practices when antibiotics are given in these populations. So why is this important? On the individual patient level or the hospital level, we see a lot of consequences for the individual patient and for our communities. So in the US, 35% of E. coli strains are resistant to ciprofloxacin. I know you can't read the text on that graph there, but that is the resistance rates of Cipro in the US. They are on the rise. I know in my home hospital, we're lucky. We're only at 22%, but Cipro is the workhorse for outpatient pylo treatment, and we are losing that drug pretty quickly. And there's not a lot of great alternatives, actually. So it is important that we preserve that efficacy. C. diff is one of the epidemics of our era, and in the CDC stats here from 91 to 2003 show that we've essentially doubled the rate of C. diff from 65 to 156 in the per 100,000 patient population. You don't need to go to life threats either. 1 in 8 patients who are given an antibiotic are going to suffer from diarrhea. I am the father of a 3-year-old, and diarrhea has a major impact on our household. And so if you need something to help convince your patients they don't need that antibiotic, these common side effects are actually very useful. And then that number at the bottom, 0.3% rate of antibiotic-related adverse drug events. That sounds like a pretty small number. When you think about the scope of antibiotic use in the US and worldwide, that number becomes big fast. So think about how many patients on a daily basis are receiving antibiotics. And as an emergency physician, the adverse drug events from antibiotics are different than from other drugs. So we're not talking about loss of libido or sleep disturbance or loss of appetite. We're really talking about rash, allergic reaction, and anaphylaxis. And so these are pretty serious side effects. These are absolutely adverse drug events that can result in death. And so we want to choose our use of antibiotics as wisely as possible. Another case scenario. So search yourself. See if you're going to be the brave soul who speaks up. We have a healthy 33-year-old female. It's her first pregnancy. She's in OB clinic for her 8-week ultrasound. And I'll add that at 6 weeks, she had a urine culture that also grew E. coli. So she now has her second urine culture that grew E. coli, and she has no symptoms whatsoever. Would we treat? And even if you're not speaking up, think in your head, would I treat this patient with an antibiotic?
Okay, it's me again. I feel like I'm hogging the mic.
Well, that was a very pregnant pause, so I appreciate you stepping up. Pun fully intended. What's your answer?
I'm going to lean toward treating this person simply because of her being pregnant and poor, what am I trying to say here? The size of the uterus, compressing bladder, ureters, although she's only 8 weeks, but concern about the development of upper urinary tract problems in pregnancy.
Yeah, so absolutely, 2 for 2. The recommendation from both ACOG, obstetrician and gynecologist, and also from Infectious Disease Society is to treat in this case. And I hope that this case was a little bit unclear for some of you. I hope some of you were on the fence, because there are a few select instances where we treat asymptomatic bacteriuria. The good thing is they're exactly 3. And I call them your hall passes. You have 3 hall passes where you're allowed to treat ASB, and this is one of them. And so in early pregnancy, there is evidence that asymptomatic bacteriuria can progress to pyelonephritis and affect the health of the mother and the fetus, and it should be treated. Here's the rub, though, and what I think a lot of people are probably treating inappropriately is this is based on 2 positive urine cultures. So it's not based on a single urinalysis in the ED, for example. I see that a lot among my colleagues as it's a first trimester patient. You run the UA, they're asymptomatic, but it does show ASB. And so we say, oh, well, the recommendation is to treat. I would actually recommend when they come into the emergency department setting, not sending the urinalysis at all unless they have referable symptoms and leaving that up to their family practice doctor or their obstetrician. But in this case, the patient has 2 positive urine cultures, and we do treat 1 time in pregnancy. If it comes back and a 3rd culture is positive, you do not treat a 2nd time. And again, we'll make those exceptions crystal clear by the end of this presentation. So going back to antimicrobial stewardship, we talked about why it's important to our patients and to our home healthcare systems, but what about the larger scope of this problem? So the science here is basically, by using antimicrobials, we are killing off, or using them inappropriately, we are killing off the easy to treat bacteria. So we're killing off the weakest herd in our community biome, in our bacterial flora. And what we're left with are the strongest pathogens, the resistant pathogens. And as we continue to apply this pressure of antimicrobials, antifungals, antivirals, antibiotics, we see that our pathogens get stronger and stronger and that they evolve and develop resistance. Now, it's not just human medicine. This is the meat industry, the veterinary industry, of course, human medicine. Those are probably the top 3 offenders. And to our credit, in human medicine, we are light years beyond the veterinary and meat industries in this field in terms of recognizing the problem and taking steps to address it. So just the fact that we have 130 participants on this call tells me that people are motivated to start chipping away at this very big problem. Worldwide, we're seeing about 700,000 deaths annually. In the US, those number are 23,000 deaths annually and around 2 million illnesses, and so from resistant organisms. And so the mortality from this is obviously huge, but the morbidity is quite large. And then it's costing us a lot as a society, somewhere between 21 and 34 billion per year, with 8 million additional patient days in the hospital. Now, anyone in antimicrobial stewardship has heard the mantra, how to prevent this epidemic from getting worse. It's the right drug, the right dose, and the right duration. And so we realize that if we take off that selective pressure, if we use fewer antimicrobials, those strains, those weaker strains actually reincorporate into our community biome. And so we start getting weak bugs again, and our drugs become more effective once again. So you can actually save, for example, ciprofloxacin if you use fewer doses of ciprofloxacin or shorter courses, obviously still treating the original infection. Now, if you notice before those 3 words, I added right diagnosis. So that's what we're talking about today is before you even get into whether or not you chose the right drug and the right duration, we've got to be sure that we're actually treating a bacterial infection that should be treated. And ASB is one of these common instances where we find that we're actually over-treating, that a lot of these patients would thrive without antimicrobials, and we're giving them all of the risk with really none of the benefit. And so that's the challenge, and it's not always easy, admittedly. If that's not enough to convince you to change your practice, there's really not a lot of new drugs coming out. So in the 80s, we had 16 new antibiotics. We had 10 new antibiotics in the 90s. In the 2000s, we were down to 5 new antibiotics. And currently, only 1% of pharmaceutical companies have an antimicrobial discovery program. Now, they are the bigger companies, so there's some hope there. But really, the low-hanging fruit of antimicrobial development has been picked. And the cellular mechanisms that they're working on now are multi-step mechanisms that require a lot of research and development. And so it's just imperative that we save the drugs that we currently have. And finally, if you're still not convinced, superbugs have arrived to the US. So this was kind of almost a myth a decade ago, these superbugs that are resistant to all antimicrobials. And this news article here is one in Nevada where a woman had a bone infection and every single antibiotic known to man did not work against it, and the woman expired. So this is already a much larger problem in Asia, and it's absolutely arrived on our shores. And so it's a public health crisis, and asymptomatic bacteriuria is one piece of a pretty complicated puzzle. But we're choosing high-yield topics here, and I think this is, because of that practice gap, one of the reasons that it's such an important issue. All right, case 3. Dr. Gerber's been amazing. I wonder if someone else is going to chime in, start thinking about it. We have a 21-year-old female who is suicidal, and she's in the emergency department for psychiatric clearance. So the psychiatric facility is considering admitting her. They want to make sure that there's not a medical cause of her psychiatric symptoms, so they've asked for a urinalysis for screening. And her UA did come back positive. Again, a clean sample, bacteriuria with leukocyte esterase, nitrites, and WBCs. She has no symptoms whatsoever other than feeling suicidal. Rubber hits the road. Does she get antibiotics or not?
See if I can go 3 for 3. I say no.
Great. And what's your reasoning?
Well, again, she's not toxic. She's not ill. She does have obviously some psychiatric issues, but not febrile, not septic, as I said earlier.
And so I'm the receiving physician at the psychiatric facility. And my clinical question to you is, are we missing delirium here? Is this psychosis from an infection?
Well, maybe so. I guess I would think of this occurring more in an elderly patient, but maybe at this age too.
So this is exactly what makes this case so interesting. So your initial clinical gestalt was spot on. This patient should not receive antibiotics. And what we see in medicine is we sometimes have to have challenging discussions with other clinicians and with our patients. And here's the challenging part of this is if someone's going to a psychiatric facility, there may be no medical staff there, or very limited medical staff there, or they might not really have the capabilities to deliver routine medical care for that. So they might not have access to IVs and IV antibiotics. And so this clinician is very leery of outside clinicians sending patients to him who are going to decompensate and get septic and have to be transferred out of the facility. So very appropriate. We're just coming from different worlds here. But bacteriuria is not going to cause her psychiatric symptoms. If we think about it, the pathophysiology we're suggesting here is that E. coli or whatever organism is in her bladder, spreads to her upper urinary tract, spreads to the interstitial tissue. She becomes bacteremic, and now she's having delirium from that. And she would really have symptoms. It's just so unlikely that a patient would have all of those things with no changes in vital signs, no urinary symptoms. We sent other labs on this patient, no white blood cell count on her serum labs, other things. And so I think we can say with confidence that this is asymptomatic bacteriuria and have a good discussion with that clinician that we probably shouldn't be treating. Now, if they're insistent, which people sometimes are, and I understand they don't have the patient in front of them, they don't know me from John Smith, and they don't know my clinical background, you can always have a more nuanced conversation and suggest a watch and wait prescription. So a middle ground would be say, okay, I understand you're afraid of me sending you a patient with delirium. How about we wait 24 hours? I'll give you a paper prescription for some macrobid. And if she develops symptoms during that time, you can start the antibiotic. And I think there's a very low likelihood that prescription would be filled. But that's the evidence is all there. And I think intuitively we know that this patient doesn't have a true UTI, but the problem is translating it into clinical practice. And we'll get these difficult conversations with patients and other clinicians. And so the power of saying things like ASB, of having that diagnosis, the power of knowing the guidelines can sometimes help us navigate those waters. Now, at this time, I think it's good to zoom out a little bit. How did we even get here? It's actually interesting. There's a lot of dogma in medicine, and we can't always track it back to how it started. But in this case, it's pretty obvious. The urinalysis was developed in 1957, and one of the initial study populations was actually pregnant women. Interestingly, pregnant women do sometimes progress on from ASB to pyelonephritis to sepsis. They found that in the studies, and the astute clinicians then extrapolated that to other patient groups. And for decades, we treated all patient groups with the assumption that their pathophysiology was similar to that of pregnant women. Well, the studies started to trickle out that that's not actually true. And now we have over 100 studies in various patient populations that shows us that this is actually a niche population. And it was just by luck of the draw that they were studying pregnant women, and they came up with that conclusion. But the logical conclusion that asymptomatic bacteriuria is pathogenic in all patient populations really hasn't panned out. But that's part of the reason that we have this dogma that we're fighting against today. Now, I call these, and I'm sorry, the slide looks like it misformatted from Mac to PC here, but I call this your hall pass. So these are the 3 evidence-based times where the Infectious Disease Society of America says it is okay to treat ASB. So once in early pregnancy, as we discussed, with 2 positive urine cultures, pre-urologic procedure, especially TURPs, and I think that makes a lot of sense actually because we're now passing a sterile instrument through the urethra, but that instrument may cause a micro tear in the urethra. You may create a false passage. There's opportunities for that bacteria that's not pathogenic in the bladder to actually go into the interstitial tissues and cause an infection. So that makes some sense to me. And then post-renal transplant, there is still a recommendation. The idea is these grafts are so precious, let's not even put them at any risk for a symptomatic urinary tract infection. Although there's been multiple studies on this, and it's showing that this really doesn't pan out, that ASB, even in the post-transplant patient, is not progressing to bacteremia and sepsis. And I actually think we're going to see this recommendation fall by the wayside. Now, it's really important to know where you're getting your recommendations from. So these are population health-minded recommendations from the Infectious Disease Society of America. But when you have clinical discussions with your colleagues, you might come against specialist recommendations. So you might have an orthopedic surgeon, for example, who says, or I'll hold off on that example, but you might have, for example, an emergency physician who says, in a patient with altered mental status, we should be treating a urine infection. And they'll have a clinical guideline from their specialty there. And what's important to note is that clinical guidelines that are specialty specific are often focused on the individual patients and sometimes have kind of a narrow scope that's specific to that specialty. And so, sometimes you got to do honorable battle with the literature and know that you're coming from a population health perspective, know that you're coming from an infectious disease perspective, and hopefully sway some minds, even though you might have a good discussion about individual patient health and risk versus population health. Case number 4, we have a 65-year-old female, and she has a positive urine culture. It was sent as screening pre-op before a total knee replacement, and she has Pseudomonas on that culture. So your orthopedic surgeon, let's say you're doing pre-op clearance as a hospitalist, and your orthopedic surgeon is requesting antibiotics to treat her Pseudomonas UTI. Do we treat or not treat? All right, I'm not going to torture Dr. Gerber, so I assume you all just took a bite of food. And in this case, go ahead. Someone. Absolutely.
Not treat, and I'm going to add one more thing to this, is
Sure.
that why test the urine? And in a couple of examples that you shared with us, the question is, why are we testing? So in this case, even the testing is not necessary, and the treatment is not.
Wonderful. So we have some astute clinicians on the call today. I totally agree with you. And at the, near the end of the presentation, we're going to talk about 6 ways to stop treating ASB. And one of those ways is to avoid screening for it. So we'll dive a little deeper on that. Absolutely. This is another evidence and practice gap. This is widespread practice. You will find in hospitals across the United States, surgeons, and I'm not picking on surgeons, I'm an emergency physician, you'll see me picking on myself throughout the presentation, but surgeons who are trying to decrease their post-op infection rates by treating asymptomatic bacteriuria pre-op. The evidence is not there. And I've actually gotten this question enough that our 4th journal club in this series is specifically on this topic, specifically for knee and joint replacements. Because, with the way that we're changing reimbursement, post-op infection is a really big deal. It's affecting who gets paid and when, it's affecting who takes ownership of a patient who comes back to the hospital. And so people are terrified, appropriately, of post-op infections. But if you think of the pathophys here, we're saying that this Pseudomonas is going to go from her bladder into either her bladder wall or up into her kidneys, into the interstitial space, into her bloodstream, and seed to the joint, all with no symptoms whatsoever. It's just very unlikely. The patient's going to develop urinary symptoms, or they're going to clinically decompensate or get fevers. if this is starting to happen. And then when you just look at the side-by-side literature, the post-op infection rates are the same, whether or not you have asymptomatic bacteriuria. So I totally agree. This shouldn't be in no protocols. The screening UA should not be sent. But obviously there's a big gap here. There's a gap between practice and evidence. And so, you know, you can't kind of barge into your surgeon's office charged up and say, we got to change this now. You got to really go through that process of having, you know, the team talk it out, looking at the evidence, having people compare guidelines, and look at rates at your infection rates at your own hospital, and make sure that we have consensus on this so we can actually change the protocol and stop the non-evidence-based practice. But yeah, kudos to you, correct answer. So if you're kind of coming into this presentation and you want to change one thing in your practice today, this is some of the low-hanging fruits. These are the areas where I think we most commonly treat ASB, and some of the things that are easiest to change in your clinical practice. So a big one is catheter myths, and we'll get into this, but catheters are so interesting because you walk by the patient's bedside and you literally see a bag of urine. You can't not see it. And when you see that dark urine, when someone catches a whiff of that foul-smelling urine, when you see sediment or pus in the bag, there's just this temptation to treat that, to test that urine and then to treat it, especially among nursing. I have to say, there's a lot of literature not just on physician dogma, but also on nursing dogma. And urine appearance among nurses is a common reason to suggest to the physician or the provider that we test the urine or treat the urine. And what we find is that foul-smelling, dark, or urine with sediment, even in patients without a catheter, is often due to hydration status or colonization. And so that does not translate to UTI, to symptomatic UTI. It should really be based on fever, flank pain, or other urinary symptoms. Convenience screening is a big issue as well. So in the emergency department, we have a lot of production pressure. We've got to get that patient out in 2 hours. And sometimes I won't order urine in my initial workup, but then the nurse has the urine in front of me and she said, hey, the patient just peed. Should I send it? And that's kind of a binary question. It's a false dichotomy. Do I send it or do I not? And there's a middle ground there, which is stop and think about it first. And so my response to that is usually, why don't you label the specimen? Thank you. Why don't you label the specimen, put it at the patient bedside, and we'll use it if we need to. But you know, sometimes we just kind of are presented with that question and we make a spur of the moment decision that really isn't in the patient's best interest. Contaminated cultures. So if your lab isn't up to speed on this, your lab may be sending contaminated specimens for culture, especially if you have reflex cultures. So if you have a positive UA is automatically sent for culture. And so if you have greater than 5 squamous epithelial cells and that urine's going for culture and it grows a skin contaminant or another bacteria, the person following up on that culture is likely, you know, a nurse leader 3 days later who doesn't have the patient in front of them. And so having that gap between the person interpreting the results and the patient is really puts you at risk for treating ASB. And so just make sure that your protocols are tight in terms of when to send urine culture. And I would really recommend decoupling the UA from the culture entirely. So they're 2 separate orders. There are some problems with that, and sometimes patient flow problems, and you could actually need a culture that wasn't sent because of that. But I think the benefit of decoupling those 2 really outweighs the risk. And then screening. We've already talked about this before, but screening for medical clearance, for psych, for jail, and even for altered mental status, which I'm going to put that one on hold because we're going to talk about that a little bit more in depth. So these are your low-hanging fruit. If there's one slide that you want to show to your colleagues, these are some easy ways to change your practice today. Case number 5, and I love that we had a new voice out there. I know there are others. Be bold, be brave, and I probably would have answered all of these wrong before I sat there and studied each one of these things, so that's why we're talking about this. We have an 11-year-old female. She's presenting with periumbilical pain. She has 4+ WBCs on her UA with no bacteria. No other urinary symptoms, but she does have the belly pain, which, you know, could definitely argue is a urinary symptom. And there's her urine specimen cup below. Does she receive antibiotics or not?
So I'm going to jump in. At my lab, we don't even go to a culture. So this is going to be a no-go.
Great. I would agree. I'd say the correct answer is probably no or maybe on this. Let's get some more information. Anyone who has done a review of medical malpractice cases or of bounce backs is going to find a clinician who anchored on a urinary tract infection in the case of sterile pyuria. So if those words aren't in your lexicon, let's introduce them right now. Sterile pyuria is a urine sample that has no bacteria but has WBCs in it. And what it shows is inflammation or irritation of the urinary tract. Here's the rub though. Inflammation does not have to come from within the urinary tract. So until proven otherwise, this is an abdominal abscess of some kind that is irritating the kidney, ureter, or bladder. Common abdominal abscesses would be appendicitis or tubo-ovarian abscess in this patient, and then diverticulitis as well. And so and I think this is something that's kind of under-taught. So I work with residents and I work with PA students as well. And we've caught, or it's come up multiple times where the trainee is ready to anchor bias. They're ready to call this a urinary tract infection, spike the football, write them their antibiotic, and discharge a patient who has active appendicitis, tubo-ovarian abscess, or diverticulitis. And so I really think this is something that we need to talk about more frequently and be aware of. This is your opportunity to avoid a malpractice suit. When you see sterile pyuria, assume badness until proven otherwise. And in the end, if it is a urinary tract infection, that's fine. But that patient probably would be well looking with normal labs, and their symptoms would take some time to declare themselves. And I agree, if your lab really shouldn't be sending this for culture. So this is not a case where this would be sent for culture. I put the urine specimen cup there too, just to be impressive. So that's a really foul looking urine because it has WBCs in it. So that's a nasty looking urine. But pyuria is a great example of how the urine can appear infected when in fact it's actually an irritated urinary tract that's not relatable to a urinary tract infection. Thanks everyone for the participation. This has been wonderful so far. I'm coming back to that easy button slide. I wanted to jump into case 6 first. So we have an 89-year-old female. She comes into the ED. She has no urinary symptoms, but she has dementia at baseline and isn't really able to provide a reliable review of systems. But she's altered today. She's combative, she's violent, she's acting different. And we do a straight cath urinalysis, so it's not an indwelling catheter, it's a single straight cath where she can normally void on her own. And it shows bacteria, WBCs, leukoesterase, nitrites, and no squamous epithelial cells. Do we treat? And let me add that there is no other apparent cause of her altered mental status. So we have done a head CT and usual labs. Normal vital signs, no fever.
Dr. Gerber, I wouldn't treat this.
Tell me more.
Well, I just think in this kind of a patient, there could be other reasons for altered mental status. Now, maybe the rest of her labs, maybe I missed that, but if you said the rest of her labs are okay, but without fever, without signs of sepsis, I don't think I'd treat this.
Yeah, excellent, excellent. So I totally agree with you, but my specialty does not. So this is, well, I think this is one of the big sins of emergency medicine, and I'll be the first to raise my hand that as an emergency physician, this might sound like a niche population, but I see this patient every single shift. I'm not exaggerating. I really think I see, on average, this patient once per shift, where we have altered mental status, usually from a long-term care facility, and nothing comes back positive except the urine. And again, the temptation is to spike the football, start the antibiotic, start your IV ceftriaxone, admit to the hospitalist, and blame it on the UTI. The evidence just really is not supporting that. What we find is that urinary tract infections are an uncommon cause of altered mental status in the elderly. Now, if we're talking about bacteremia and sepsis, that is a common cause of altered mental status, but you should really see those. And of course, occult sepsis exists, but if you get a normal lactate, no WBCs on their peripherals, on their serum blood, they're not having fever, they don't wince when you tap on their costophrenic angle, it is unlikely that the urine is causing this altered mental status. And so what are other causes of it? Medications is a big one. So medication interactions. too much of a medication. So if a patient's, for example, if a patient's dehydrated, their renal function's a little bit compromised for a temporary state, and then their medications build up in their bloodstream, they can be oversedated. Sundowning or sensory delirium of any kind is a common cause of this. Dehydration, again, is something we see. There's less of a thirst reflex in the elderly. And so it's still standard of practice, I would say, across the country to treat this patient. And I think that's being done incorrectly. So what we've done at our hospital is a pretty novel protocol that we've been sharing with other health systems, and there's a few early studies on it. I think there's going to be more literature to really show that this is a best practice. But in our hospital, we wait. We do a watch and wait strategy like Dr. Gerber suggested, and I'll call my hospitalist and I'll say, I have an altered elderly patient, nothing's panning out. Sometimes I won't even send the UA, to be honest. I'll say they don't have any urinary symptoms, I haven't sent a urinalysis, and I'd like to admit them for medication holiday, IV hydration, and a watch and wait strategy. And if that urinalysis was sent, you can wait 24 hours and see if the patient either develops symptoms, develops fever, or deteriorates clinically. And if any of those things start to happen, absolutely start antibiotics. But the reason this is so important is because our nursing homes, our long-term care facilities, are clinical environments where multi-drug resistant organisms thrive. And the reason that is because the patients themselves are at risk for overtreatment. So because of their functional limitations, because of their inability to provide accurate review of systems, not just the altered elderly, but the elderly patient in long-term care in general is more at risk for having asymptomatic bacteriuria. And just having this condition puts you more at risk for being treated with it. And if you are treated time and time again, so the experience I have is the family member who says, oh, this happens once a month, it's always a UTI. And that's a hard argument to make an argument against when a family member is telling you the diagnosis. But if this patient is receiving an antibiotic every single month of their life, it's pretty likely that at some point they're going to have a resistant organism. And so we find that long-term care centers are actually parts of, like, areas in our community where long-term or where resistant organisms can develop and thrive, and of course spread to the rest of the health system. So cases like this are actually really critical. And if this is happening commonly in your hospital, which it probably is, you might want to have a talk with your emergency physicians or your ID department and talk about strategies to combat that. I'm going to go back to the big six. So this is developed by me based on the literature, 6 easy steps to stop treating ASB, okay? And we're gonna go through one by one and talk about each of these. I think we're actually doing pretty well on time here. So the first is to recognize the problem. That I think we're doing that just by participating in this webinar. So I don't know if you remember, this is when Obama and Biden signed the ACA, Biden whispered in her ear, this is a big effing deal, and he had it on a hot mic. So this is a big effing deal. 80% of the time, we're using antibiotics inappropriately. And just recognizing the problem is a big step towards changing our practice. The other thing to do is recognize high-risk populations. So we've talked about a lot of them already, but the patients with an indwelling catheter, 100% or near 100% ASB. Spinal cord injury with doing intermittent straight caths, 50%. Post-urologic procedure is also a high, or anyone who's been recently instrumented in the bladder. The specific numbers are pretty messy, but it's recognized to be a high risk population. Long-term care residents or anyone with limited functional status or inability to clean or limited inability to clean, and then diabetic and pregnant females. So these are your high-risk populations. If you're seeing a, quote, positive UA in any of these populations, just think about that. You know, your spidey sense should be tingling. Is this ASB? And we talked about screening, okay? Every time you send a UA, you should have a good reason for doing so. And there are some enemies in our healthcare system against this. So one of the big ones is reflex cultures we talked about, automatically sending a urine culture. Another one is order sets. So I know I have a lot of, you know, I've been to health systems, for example, where a chest pain workup has a urinalysis on it, and it's a default order, and you have to actually unclick the urinalysis for a chest pain workup. Even for abdominal pain, does that really need to be a reflex order? And that's something that you'll have to talk with your other clinical team and your ID department and decide whether that belongs there or not. Nurse-initiated protocols, I think, are a wonderful thing, especially in the emergency department. We rely on that heavily, but the protocol really needs to emphasize symptoms, because there is no nursing dogma out there about the appearance of urine or the smell of urine being indicative of a urinary tract infection, which has not panned out in the literature. And And then if a UA was ordered to evaluate for non-infectious symptoms, for example, if you want to see if a patient has proteinuria, and then you find an incidental, quote, UTI, that's a time when we have to slap ourselves on the wrist and say, wait a second, this patient's not really having symptoms of a UTI. Let's do a watch and wait strategy or not even send it for culture at all. And Shruti, who's our coordinator here, is actually going to send out an article that summarizes all of this evidence. So you'll have an article at your disposal. And then UW Health is very generous with their protocol. So they have a clinical protocol that really highlights a lot of these points and has been vetted by their infectious disease department. It's widely available on their website. It's not proprietary. And so we're going to include that as well so people can show that to your infectious disease team or your any clinical team if you want to start addressing any of these issues. A fourth thing that we can do is recognize when a urinalysis or urine culture is being sent for the wrong reasons. So these are the myths. A Foley catheter patient with no flank pain, no fever, no sepsis really shouldn't be treated for UTI based on urine culture, urinalysis, urine appearance, any of those. We talked about this already, but foul smelling and dark urine are not related to UTI, usually more related to hydration status or colonization. And then any of these things, screening, reflex orders, convenience samples, the incidental UA, just be aware that those are happening on a regular basis and see if there's gaps in your protocols where you might be able to minimize those things. We can diagnose UTIs with sophistication. So, I'm curious to know if the audience recognized this, because this was a fact that when I read it, I was actually quite shocked. 34% of the time to 50% of the time when women have dysuria, and we talk about women so frequently because they're at much higher risk for ASB than men are, but when women present with urinary symptoms, they do not have a UTI. And one of the common mimics is either bladder spasms or concentrated urine. So even when you do have someone with urinary symptoms, that does not necessarily mean UTI. Pyuria does not equal UTI. That's more inflammation of the genitourinary tract and should be accompanied with symptoms and bacteria. And leukocyte esterase and nitrites do not equal UTI. So one of the things that I used to ask people, did you learn in med school that urine was a sterile fluid? I stopped asking people that because we all learned in med school that urine was a sterile fluid. Urine is not sterile. There are studies where they go in with a sterile catheter and take urine samples directly from the kidneys or the bladder and run PCR on them. And what they grow is a rich biome of bacteria. And the urinalysis technology that we have, that our lab uses, is designed to detect pathogenic bacteria. And so we have a natural urinary biome, and sometimes the ratios get out of balance. Sometimes we see that our natural biome is producing bacterial metabolism byproducts like leukocyte esterase or nitrites without having pathogenic bacteria in the urine. Sometimes it is pathogenic bacteria, but it's a temporary state. And after our next void, we're going to urinate and flush that bacteria out of our system. Sometimes it's pathogenic bacteria, but we just happen to be colonized. And for whatever reason, it's not invading our bladder wall. It's not progressing to the kidneys. It's not progressing to bacteremia. And our body has found a way to achieve homeostasis with pathogenic bacteria. And then, of course, there is the risk. You got to acknowledge this could be an early UTI that is just waiting to rear its head. But if that is the case, it should do so in a predictable, slow fashion over days. And you should have time to recognize those symptoms and treat when it's appropriate. Positive culture does not indicate UTI. I think we've talked about that quite a lot, but there's other reasons for bacteria to be in the urinalysis besides UTI. Contaminated samples is a big one of them, or a colonized sample. And then we talked about UTI and altered mental status in the elderly. It's actually a very uncommon cause of altered mental status in the elderly. And so if we anchor on UTI as the cause of altered mental status, we're putting ourselves at risk, and the patient, of missing the true diagnosis. So that's an opportunity to avoid anchoring bias. And then this is a new topic we haven't touched on, but once resistant, always resistant. That is a myth. So if the last time you had a urinary tract infection, you grew E. coli and it was resistant to macrobid, there is equal chance with your subsequent UTI that it will be susceptible to macrobid, or at least I should say equal to the general population. So just because you were resistant before doesn't mean you're going to be resistant next time. Now, interestingly, the flip side is true. So if you were susceptible to macrobid last time, it's likely that you will be susceptible again. And so this is a good just kind of, I know we're not getting into treatment in this conversation, but this is a good pearl to have in your back pocket, that just because someone was resistant before doesn't mean they need a carbapenem this time, doesn't mean they need a fourth-gen cephalosporin every time they get a urinary tract infection. And then finally, this is my favorite. This is the best for last. Free text the real diagnosis. Words have power. The medical chart, you are going to see patients' previous diagnosis over and over again. And you have the power to leave etched in stone, not real stone, but etched in data in their medical record that they have asymptomatic bacteriuria. So when the next provider sees that patient with no urinary symptoms and sees that positive UA, they can pause and think, is this ASB again? And this is not commonly in menus, so that you might not have ASB in the menu on your electronic health record. And if that's the case, see if you can get it added on, or see if you can just inform your colleagues to free text that diagnosis, because I think the power of words here is especially relevant. Now, we've talked a lot about theory, and it would be wonderful if you could walk into your hospital or your clinic and just make all of these changes snap into place immediately. But the reality is we have a lot of colleagues that we have to interact with. We have patients who are expecting antibiotics, and we have a lot of soft calls. We have cases where we are not sure ourselves. So I hope that some of you had the experience when we were looking through those cases where you weren't quite sure, and you were kind of, 51% one way, 49% the other, 70-30, whatever. And so here are some strategies that I use when I'm confused, because again, once a shift at least, this still confuses me, or I'm still not totally confident in my decision. So first is consider a watch and wait prescription. We know from the literature on otitis media that only 40% of those prescriptions are filled. And those are from parents with crabby children. So if a healthy patient has what we think may be ASB, but they don't want to come back, maybe they're homeless, maybe they don't want to pay another copay, we can always give them a physical prescription and say, hey, if you just develop fever, if you develop dysuria, if you develop frequency in the next couple of days, go ahead and fill the prescription. I think that's a reasonable approach. If possible, you can wait for culture results and call the patient back to reconfirm symptoms. There's a lot of protocols in place already to do that. I really prefer to do it yourself if possible, especially in the family practice setting, because you saw the patient initially and you can say, hey, have your symptoms evolved? How have they changed? Or at least have some sort of messaging system in place. So if a nurse manager is doing that role, they can be informed of whether or not the patients initially had symptoms or what they were. If you're admitting a patient with ASB, consider a tincture of time. Consider waiting 24 hours to see if they develop symptoms. Presumably they're monitored, they're in a medical setting. The chance of them progressing to sepsis in that time frame and resulting in serious harm is very low. And then when you are choosing to treat a soft call UTI, so again, we're not talking about all UTIs here, but when you think this may be ASB, it may be a UTI, I'm not totally clear, well, that's an opportunity to use one of the drugs that doesn't really contribute to resistance as much. So for your soft call UTI, please don't use ciprofloxacin. Consider something like macrobid, Bactrim, a first-generation cephalosporin, if that's appropriate in your hospital. Obviously, we all have different biograms. You have to take that with a grain of salt in terms of your context. And then finally, you can just talk with your patient about it. Inform them of the risks of antibiotics. So, hey, I'm putting you at risk for resistant organisms, for adverse drug events, for antibiotic-related GI upset or diarrhea, and the cost of this antibiotic on a soft call. Is that worth it to you, or would you rather do a watch and wait? I mean, some patients are diehard. They will not leave that office until they get the antibiotic. You don't have to spend you don't have to bang your head against the wall the rest of your shift because of this challenging interaction. But you can inform them of the risks and benefits and see if that sways their opinion. So this is our final case, all right? Everything up till now has been a patient with no symptoms. This patient has symptoms. She's 35 years old. She's in your clinic. She has 1 day of dysuria and frequency, and her UA is strongly positive, except it does have greater than 5 squamous epithelial cells. Do we treat this patient or not?
Hi, Dr. Gerber again.
Hey, Dr. Gerber. I'm very glad you're on this call. He is not a plant. He is receiving no financial compensation from WHA. What do you think, Dr. Gerber?
So I think this is probably a poorly collected specimen with the squamous epis, and I would tend to not treat. Maybe hydrate, and if symptoms persist, maybe repeat a urine some days later. But I say not treat.
I totally agree. And so this is challenging. This patient may well have a UTI. They may have a UTI. And the question is, or the rub here is that this is a bad sample. This sample is entirely unreliable. And for any of us who practice diagnostic medicine, you've had this situation play out time and time again, where a contaminated sample looks horrendous, 10,000 bacteria, we use PCR bacteria, but 10 plus bacteria, and then the second subsequent sample is totally clean. And, this may have skin flora that's contributing to it, multiple other reasons why the contaminants would cause the urine to look this way. And so in the ED, we actually have some time. I can have that patient sit around, and my rule of thumb is go to straight cath next, and then after 3 contaminated samples, if I've sent it 3 times, 3 strikes and you're in. If I've sent 3 times and continue to get a contaminated sample, at that point I throw up my hands, and for the reasons of convenience, we'll treat for urinary tract infection. If you're in a clinic setting, I love that idea of coming back later with a repeat sample, or if the patient's willing to wait around for a repeat sample. I think it's really worth it. Another option would be a watch and wait prescription. But we saw those numbers before. 34 to 50% of the time that women present with dysuria and frequency, it's not related to a UTI, which is really remarkable. That's a practice changer for me. And so in this case, it could certainly be a UTI, but we don't have enough information yet. Let's dig a little bit deeper, or at least give this patient the tincture of time. So that's the end of the presentation. We do have actually just 5 minutes for questions if anyone wants to chime in. But my closing thoughts here is that urine is not a sterile fluid. There is a healthy biome in the bladder, and not all bugs are bad bugs. Here we have 4 sources telling us that transient bacteriuria is common in healthy young women. I hope you learned something today. I hope there's something you can bring back to your group that's practice changing. And all of the citations are there, but we're also going to send you a follow-up article and clinical policy to help you understand some of the nuances of these topics. So with that, I'll leave it open to questions.
You can either type in the questions in the chat box, or you can go ahead and unmute your line and just shoot them at us.
I should add that this conversation is always ongoing. So my email is bobby.redwood@gmail.com. I'm also available through the Hospital Association, and we have a improvement action network where we talk about these topics. So you can always re-engage with us if you want if you have specific questions or clinical policies or anything like that. Any questions coming up on text?
Nope, not right now. So if you do have any questions later on, go ahead and email them to us. I will be sending you, sorry, I think maybe there's one. Hold on. Let's see.
Oh, that's a great idea. So the question was, what about treating with pyridium? That's totally reasonable. So this is, antibiotics are a pretty new technology. They've been around about 100 years. Before antibiotics, not everyone died of their urine infections. So urine infections will be cleared naturally. So even a pathogenic infection, if you hydrate somebody up and give them pain control, there's a good chance that that's not going to progress on to sepsis or bacteremia. And so absolutely, send somebody home with a soft call with pyridium. And that's an opportunity for the patient to clear, even if it is a true infection, to clear that infection naturally. And just let them know, hey, this could be a real infection. If you're getting worse, not better, come back to us. Very appropriate. So that was a great question.
Okay, I don't see any more right now. So thank you all for joining our first journal club. Hopefully you found this format useful. We'll continue to tweak it as we have more of these events. I'll be emailing all the registrants a document with instructions on how to get your CME. Please note that the portal will be active starting right after this event, and it's going to close May 5th, 2018 at 4 p.m. Central Time. You can't do it after, and we can't really help if you miss that deadline. If you have any questions or suggestions for us, please don't hesitate to call or email us. And we hope to see you all at the next Journal Club, which is going to take place at the same time, noon Central Time. And the title is Evidence-Based Strategies to Avoid Prescribing Unnecessary Antibiotics. Thanks, everyone, and have a good rest of the week.
Oh, can I quickly ask a question?
Sure, yeah.
Of course.
Sorry, Dr. Redwood, I wanted to say thank you so much for bringing this to our attention. I think that's a really wonderful presentation, and I plan to share lots of good points with our team. I wanted to ask you, though, just your opinion, what was the most impactful thing that you did either through your antimicrobial stewardship team or just in the ED or, you know, however you were sharing or teaching? What was the item that had the most bang for the buck that helped your team kind of learn more about this particular topic?
Yeah, that's a great question. I'm going to zoom out from this particular topic and refer you to the CDC's playbook. So the CDC actually has a playbook for hospitals, large health systems and small health systems, on how to do good antimicrobial stewardship. And so if you're looking for a roadmap on how to change antibiotic use in your hospital, there's a great evidence-based roadmap out there provided by the CDC. For asymptomatic bacteriuria, I would say, that's a great question. I think, you know, I'm an emergency physician, and so I have a lot of sway over my colleagues in emergency medicine. And so I think in our emergency department, we've really revolutionized the way we think about and address asymptomatic bacteriuria. From a hospital level, we absolutely did a med staff presentation which raised a lot of good questions. And then we're working on clinical protocols and policies through the Antimicrobial Stewardship Committee. But I think that's probably the biggest impact, is to change the protocols that are in place. So even if new clinicians come into the system, even if your Antimicrobial Stewardship Committee moves on to other topics, you have the infrastructure in place to treat urine infections appropriately. And then I had a question also from Dr. Gerber there. Any thoughts about patients doing intermittent straight cath? And I actually would like to hear a little more on that question. So what's the specific question there? Are we still live?
There, I unmuted myself.
Oh, no problem.
So would you treat these patients similar to people with indwelling catheters in terms of, I have a fellow who's got a dystonic bladder and he does intermittent straight cath 3 or 4 times a day. And he started calling because his urine looked dark and it smelled funny, kind of the same thing. I mean, and of course he wanted a culture or wanted a urine and a culture, and he grew out bacteria. So I didn't treat him, but it was quite a discussion with the family, and he was not febrile, not sick, not septic.
Yeah, I would approach that patient in the same way as a patient.
Okay.
Catheter. I think you did the right thing, and
Okay.
I totally appreciate the family. That is one of the hardest parts of this that we only scratch the surface of. But there are strong expectations from the community about receiving antimicrobials, and to address the previous question, that's another thing you can do, is get the word out in your community that not all urine infections are bad infections, because we've got to work on the community as well to let them know, because this is not a hospital problem. This is a worldwide community problem. So, but yeah, great question. I treat them like a Foley catheter patient.
Thanks again for the presentation.
Yeah, thanks for helping out with the case presentations, and everyone else for tuning in. Great lunch topic, right? All right, I think we're going to leave it there. We're always available offline, and we'll see you next time.